Arup Kumar Kundu. So let's see the insights. So there are markings on the description. Rubber. Okay, so it is a fine, bore, flexible red rubber or polythene tube with external circumference of 8 mm and length of 90 centimeter. The blind bulbous tip contains a lead shot inside the tube to facilitate passage of the tube onto the esophagus. So talking about the description of the Rolls tube, it is a fine, bore, flexible wet rubber or polythene tube. So it is basically a transparent tube. It is a very flexible tube with external circumference of 8 mm and an internal, not internal, the external circumference is 8 mm and the length of the tube is 90 centimeters. The blind bulbous tip contains a lead shot inside the tube to facilitate passage of the tube into the esophagus. It is heavy and thus it is easier for the patient to swallow the tip. Okay, so it's heavy, so it is easier for the patient to swallow. The blind bulbous tip, it contains a lid shot, so it facilitates the tube to go into the esophagus and thereby get to swallow further. The lower end of the tube is perforated by a number of side holes at different levels to allow easy section of gastroduodenal contents. So Rice tube is basically the lower end of the tube is perforated by a number of side holes at different levels to allow easy suction of gastroduodenal contents. So the lower end is having number of holes, and these holes will help with the suction of contents of the gastroduodenum, gastric and duodenum, stomach and duodenum thing. Okay, there are four circular markings in the body of the tube. So there are four markings of the tube. This is the rubber tube, transparent tube, polythene tube. Okay, so you have to remember transparent rubber polythene tube. Okay, it is, it has four markings. The first marking is a single circular marking and is placed at distance of 40 centimeter from the tip, and it indicates the distance from the upper central incisor teeth to the from 40 centimeters from the tip, that indicates the distance from upper central incisors to cardiac orifice of the stomach. So cardiac orifice of the stomach to the upper incisors, that is 40 centimeters. And the second marking is 2 circle. It indicates the distance between upper central incisors and the body of the stomach. Okay, the tube has been reached to the body of the stomach and it is 50 centimeters. Okay, the third marking is 3 circular markings. It indicates the distance between the upper central incisor teeth and pylorus, 57 centimeters. Distance between the upper central incisor teeth, so it indicates distance between the upper central incisor and the pylorus. So it is more deeper inside. The fourth marking is the circular marking. It indicates the distance between the upper central incisor and first part of duodenum. It means the tube has reached duodenum when the fourth marking is seen at the teeth. So the fourth marking has four circular marks. So how do you see? So when you're keeping the Rice tube inside the patient's mouth, okay, you started keeping. Okay, you see this. There is a single circular marking on the tube present, and it is present on the upper incisors. Okay, when you see that, you will get to know the first only one circular marking is there. It means it is 40 centimeters. It means the tube is in the cardiac orifice of the stomach. Then the two, if you see the two, then you push inside more further, then you see two circular markings. Then you can say it is in the body of the stomach, which is 50 centimeters. Then you see the third marking, three circular markings are there. It is 57 centimeters. It means it has reached to the pylorus. Then you push further inside, then you will see the four circular markings are visible. It means the tube has reached up to the duodenum. Okay, let's talk about the discuss further about it. So we have discussed about Ryan's tube, which is having four markings. First marking is only having one circular marking. Second marking is two circular markings, and third is three circular markings, and four is four circular markings. So when you see the four circular markings at the on the tube, which is on the incisors, you see that the tube has reached to the duodenum. Okay, so this length will be from upper incisors to the duodenum, which is 65 centimeters. Now the base is the open end is usually plugged in by a conical plastic cap and is used to fit with the nozzle of a syringe to push or to draw materials from the stomach. So Ray's tube is usually sterilized by keeping boiling water for 30 minutes or by gamma ray radiation. So these are the two methods of sterilization which can be used in the topic of sterilization. These questions can be asked. Okay, for boiling water for 30 minutes or gamma X-ray radiation, and the base of the tube is plugged by a conical blast because there is a conical plastic cap. So it is for the nozzle syringe to fix the nozzle of the syringe to push or pull the contents. So Ray's tube you can use for the uh, in poisoning cases also, where you can take out the contents, or for feeding also. Okay, so there are two purposes by this you can stand. The tip is made blunt to avoid trauma during introduction. So the tip is usually blunt. The tip is made blunt to avoid trauma during introduction. So the tip is made blunt to avoid trauma during introduction. So the tip is blunt. The tip is blunt to avoid trauma during introduction. The tip is blunt to avoid trauma during introduction. So the tip is blunt to avoid trauma during introduction. So the tip is blunt so that there's no trauma. If the perforations near the lower end are placed at the same level, if the perforations near the lower end are placed at the same level, the tube may be easily torn during manipulation and is blocked with openings at the same level by food debris or sticking to the mucosal surface of stomach. It will hamper suction or gastroduodenal contents. Health tube is available in different sizes. A tube with smaller diameter is used in children. Instead of lead shot, polythene tube usually contains three radio opaque metal balls so that it can be identified on x-rays and other investigations. So if the perforations near the lower end are placed at the same level, there's a lot of chance of you know torn or blockage, okay, by the contents. So that's why the perforations are not at the same level. Okay, now instead of let's if for children there are different diameters, so based on that you have to based on the patient you have to decide which one you have to be using. Okay, next is how to be sure that the tip has reached stomach. So it is confirmed by following methods. You might keep that into the lungs or trachea. So how do you confirm this it's confirmed by many methods. One of that is apply a 50 ml syringe at the open end of Ray's tube, inject air into the tube by pushing with a single rapid thrust. So what you have to do is to take a 50 ml syringe, inject the air into the tube by pushing the piston with a single rapid thrust and simultaneously aspirate the gastric. So put your stethoscope to it. Okay, a gurgling sound confirms the position of the tube in the stomach. So aspirate the gastric contents. What you have to do is aspirate the gastric contents. So when you aspirate the gastric contents, the contents come out freely. The tube is in the stomach. So those who are watching, very very welcome to our classroom where we are discussing the audio version of the textbook. Let me know in the comments whether it is helpful or not. The contents come out freely if the tube. So aspirate the gastric content. The contents come out freely if the tube is in the stomach. So now aspirate the contents. So how do we confirm? So other method is one method is push the air and then auscultate at the epigastrium. The gurgling sound will confirm. Second method is aspirate the gastric contents. The contents come out freely if the tube is in the stomach. Acidic nature of the gastric contents can be confirmed by litmus paper test. Next is fluoroscopy or straight X-ray of the abdomen shows the exact position of the tip of the tube, and the tip contains a lead shot or radio opaque material. If the tube is passed falsely into the respiratory tract, the patient complains of a choking sensation, violent cough appears, and peristalsis for a long time. So another method is because there are lines uh, like a fluoroscopy or a straight X-ray of the abdomen shows the exact position of the tip of the tube, and the tube contains lead shot or radio opaque material which will glow on the X-rays or fluoroscopy. If the tube is passed falsely into the respiratory tract or trachea, patient will have choking sensation. The patient will start violent coughing, and it persists for a long time. Air comes from the open end with breathing. So when air comes from the open end with breathing, then it means that it is from the respiratory tract. Yield of aspiration becomes nil. If we aspirate, there will be nothing coming out. There will be only air. So in this situation, take out the tube immediately and try to reintroduce it cautiously into the GI tract. Why the nasogastric tube is named after Ryle? So far, too many varieties of nasogastric tubes have been discovered, but tube designed by the physician John Alfred Royal of Guy's Hospital Medical School is the most acceptable and commonly used type because the Royal's one is most commonly used. That's why. So there are too many varieties of nasogastric tube, but the tube designed by the physician Royal from the Guy's Medical School, Hospital and Medical School, is the most acceptable and commonly used type of the nasogastric tube. Royal so the first the patient is first explain about the procedure in order to obtain maximum cooperation. Ask the patient to lie flat in bed with extended neck. We'll ask the patient to extend the neck. Awesome game. I think it can't be able to play. That's no issue. So whilst tube, first the patient is explained the procedure, and then ask the patient to lie flat in the bed with extended neck. He has not to flex but to extend the neck. Okay. So move the neck away from the chest, which means extension of the neck. The selective and clean of the lubricated tip of the jelly with his hands. Slowly as patient to push, be sure that the tube is in the stomach and not within the trachea. Or trachea itself and not in the trachea but in the GI tract. So if there's a choking sensation, patient is coughing for a longer time, then you can say that actually a wrong thing. The tube is in the trachea. So take it out and then cautiously reintroduce. Take it in case of a comatose patient where the protective cough reflex is lost and the tube may be introduced within the trachea without any alarming signs. So lastly, the base of the tube is kept adhered with the forehead by a leukoplast and the open end is usually plugged except in the intestinal obstruction when the open end is kept open to allow continuous drainage. In a restless patient, hands should be tied, okay? The base of the tube is kept adhered with the forehead by a leukoplast and the open end is usually plugged. Okay, so in a restless patient, the hand should be tied, or the procedure will be very difficult. Conventionally, the tube should not be kept for more than 48 hours. After 48 hours, the tube should be smeared daily with some antiseptic solution, thus withdrawing it only for 2 inches, the part lying within the nose, and then reintroducing it. So it should be only for 48 hours in the body, and after that, you have to take out from the patient's nose. The tube should be smeared daily with some antiseptic solution by withdrawing it only for 2 inches, but lying within the nose, and then reintroducing it. Okay, do not force the passage of Ryle's tube if persistent resistance is felt. If repeated failure, try a smaller gauge tube. Okay, Now, talking about different uses, so diagnostics. So to confirm upper GI hemorrhage. So if you put the tube, blood will come out. So you can confirm it's a hemorrhage in the GI tract. Fractional test meal, virtually obsolete nowadays. Fractional test meal test. So we are not doing this. To isolate AFP from gastric juice in a child who is suffering from pulmonary tuberculosis. To isolate AFB from gastric juice in a child who is suffering from pulmonary tuberculosis, children usually swallow this sputum or a patient who cannot and if the tube is in the trachea, you will be having some signs like patient complains of choking sensation, cough, will persist for long duration. Air comes from the open end and need of aspiration becomes a little bit because okay, it will come out. So lastly, when the tube is kept, then we have to be fixing the tube, the leukoplast, and conventionally the tube should be kept only for 48 hours, and if the tube is more than 48 hours, if the tube is kept, then you have to be very specific about the sterilization thing. So I mean, to prevent the infection, so and it should be cleaned with antiseptic solution by withdrawing it only for 2 inches and then cleaning the part which is there in the nostril should be cleaned and then we introduce it. Do not force the passage of the Rayleigh tube. If persistent decision fails, then change the gauge of the tube. Use a smaller one. Normally, the diameter or the diameter will be 8 mm, and if you need the smaller one is to confirm upper GI hemorrhage, which is a which can be used for the diagnosis, but it's not the diagnostic, of course. Second is fractional meal test, which is obsolete now. Third is to isolate acid fast bacillus because when the gastric juice because they swallow the expectorant of the sputum. So in children's poisoning, again of course with copper sulfate, alcohol, etc. Or kerosene oil, paraffin, petroleum poisoning. It is unsuitable. So to aspirate the duodenal secretions for non gastric outlet obstruction, is just with exceed 200 after over fasting. Okay. Therapeutic nasogastric feeding. So it's very important. Nasogastric feeding, nasogastric suction, acute intestinal obstruction to remove abdominal distension, bowel acute pancreatitis, Crohn's disease and intestinal fistula, where we have to empty the contents of the bowel, acute dilatation of stomach, acute abdomen, post-operative and GI tract hemorrhage or perforation, paralytic ileus, gastric wash, lavage done, pylori, stenosis, non-corrosive poisoning, drug overdose, and severe hiccup by ice cold water or solid bicarbonate solution. Medication in comatose patient, it can be used as a tourniquet. Okay, for medications in comatose patient, we use for gastric wash in case of pylori stenosis, non-corrosive poisoning, and severe hiccups by ice cold water, sodium bicarbonate solution. Talking about gastric contraindications, which is the most important part. So gastric lavage contradiction is seen in corrosive poisoning, because in corrosive like alkali or acid poisoning, the esophagus can perforate because the esophagus is getting softer and more risk of perforations there if you introduce the tube. Kerosene oil, paraffin or petroleum poisoning because there is a chance of lipid pneumonia, so don't use. Nasogastric feeding is unsuitable if stricture of upper GI tract is there. The upper GI tract structure is there, gastric stasis is there, patients with high risk of aspiration. The two main indications of use of gastric tube, nasogastric tube, Ryle's tube is aspiration, gastric and other nutrition supplementation of patients. Left lateral position of the patient facilitate the recovery of gastric juice. The two main characteristic indications is aspiration of gastric content have presence of perforation or abscess like CVA, hepatic